Hills and Valleys is a podcast that uncovers stories from leaders in healthcare, tech, and everything in between. Straight from the heart of Silicon Valley, we give you a look at the good, the bad, and the future, one episode at a time. Brought to you by Potrero Medical.
One of the things that I think would be really important in the future is to predict and prevent patients from experiencing critical illness or deterioration in their conditions.
Hey everyone, Omar M. Khatib, Director of Growth here at Potrero Medical, and that was a short clip from our interview with Dr. Robert Stevens. We caught up with him at the Society of Critical Care Medicine, where he was chairing many of the discussions around the use of artificial intelligence in the world of critical care. And we decided to catch up with him to get his insights in terms of the world of medicine as it relates to precision medicine, predictive health, and how artificial intelligence fits into there. Now, Dr. Stevens is a fellowship-trained and board-certified physician in critical care medicine, neurocritical care, and anesthesiology. Currently, he is the Director for Laboratory of Computational Intensive Care Medicine and the Associate Director for the Precision Medicine Center of Excellence at the Johns Hopkins University. He also holds joint appointments in neurology, neurosurgery, and radiology at Johns Hopkins. Now, Dr. Stevens' vision is to deploy precision medicine for the benefit of critically ill patients. His research aims to discover and validate patient-specific biological signatures associated with things like trauma, surgery, and acute conditions such as stroke, cardiac arrest, sepsis, and acute kidney injury. Now, to achieve this, he engages with an interdisciplinary group of basic and systems neuroscientists, biomedical and computer engineers, biostatisticians, data scientists, and neuroradiologists. Now, one reason I really wanted to talk to Dr. Stevens is that, as you can tell, he has a variety of connections and involvement with very high-level research projects that will essentially affect the practice of medicine in many ways. To name some of these projects, one of them is that he's the principal investigator for the Neuroimaging for Coma Emergence and Recovery Project, which examines MRI features of the brain connectome to enhance classification and prediction in patients recovering from severe brain injury. And some other projects in Dr. Stevens' groups analyze features captured through neurophysiologic monitoring, structural and functional MRI of the brain, serum biomarkers, wearable sensors, and all of which have the goal of enhancing classification and prediction in vulnerable acute ill patients. And in the lab, his group studies molecular and cellular determinants of injury and recovery in experimental models of traumatic brain injury, stroke, and sepsis, with a special emphasis on neuroimmunological responses and cellular regeneration. So we were really excited to sit down and talk to him. I know you'll enjoy this episode. A lot of value, a lot of insights on the future of medicine as it pertains to prediction and precision. So without further ado, here is the episode with Dr. Robert Stevens. All right. Hey everyone, this is Omar M. Khatib, Director of Growth here at Potrero Medical, and we're joined by a very special guest, Dr. Robert Stevens, who I got the pleasure of meeting at SCCM. It was a fantastic background. He's currently at Johns Hopkins University, and I'm going to go ahead and pass it off to him. Dr. Stevens, thanks for joining us. Can you give us a little bit of your background and your current role at Hopkins?
Hi, how are you? My name is Robert Stevens. I'm an associate professor in the Department of Anesthesiology and Critical Care Medicine at Johns Hopkins University School of Medicine. I have also joint appointments in neurology, neurosurgery, and radiology. I'm the co-director of the Precision Medicine Center of Excellence for neurocritical care, and I also have a very robust research program, which is primarily dedicated to optimizing the care and outcomes of patients admitted to the ICU using computational and quantitative methods.
Fantastic. Now, Dr. Stevens, one question I have to ask. We have a lot of people who are listening who are pre-med and medical student, and of course residents. So, just out of curiosity, what got you into medicine? Why did you decide to go into medicine?
Yeah, that's a great question. I started off, my studies with an interest in actually topics that are quite remote from science and medicine. I was very interested in philosophy, political science, literature. But little by little, I came to have a sort of deeper understanding of what is involved in being a doctor and the sort of scientific approach to evaluating and treating human health and human disease. And this occurred over several years, multiple discussions with friends and family. And finally, I decided that, this was probably the right thing for me. So I entered medical school. And I must say that it's been a great experience, a great adventure. I do not regret it in any way.
Fantastic. And after medical school, what did you decide to go to do your residency and training, and why?
Yeah, so I grew up in Switzerland, and having completed my medical training, medical school, I subsequently went into residency training. So I did, different. I went into different areas: internal medicine, surgery. And then I became rapidly fascinated with intensive care medicine through my rotations. And so that's when I decided to do an anesthesiology residency. And during that residency, I had the opportunity to work for many months in the intensive care units. And so then I followed up with fellowships. So I did actually three different fellowships in intensive care and neurocritical care. And then simultaneously with all this, one of the reasons, why I entered medicine and why I remain in medicine is because of the science, because of the research. And so throughout my career as a student, as a resident, as a fellow, and now as a professor, I've been very passionate about trying to advance the science in this field, and so this has been a major preoccupation of mine: is how can we gain greater knowledge on health and disease using advanced methods.
Yeah, and speaking of which, so you and we first met a couple weeks ago in Orlando at the Society for Critical Care Medicine, and you were leading a lot of these sessions and panels on artificial intelligence and machine learning, which really I thought was very well done. Just because even though we talk a lot about it in medicine, I don't think there's a lot of physicians who, number one, have a good understanding and command of what AI in medicine looks like, and more importantly, they don't necessarily do a great job of translating that to their peers. But your sessions were really fantastic. So when it comes to like AI as it applies to precision medicine, like what are some things that you're genuinely excited about, and why?
Yeah, so I think you bring up several interesting terms. So first of all, precision medicine. So this is something that I've been personally invested in for several years. I think that we are at a unique time in our history when we have the ability to acquire extremely detailed, high resolution, high frequency information on human health, right? And so this can include obviously genomics, imaging, data from the electronic health records. And so we are currently, we have an unprecedented amount of data that is accessible and that can be leveraged. And so simultaneously with that, we have techniques like artificial intelligence, and in particular machine learning, that allow us to effectively and efficiently analyze these complex data sets and extract knowledge that can be helpful to understanding health and understanding disease and how to treat them. So I think that the convergence that you talked about of precision medicine and artificial intelligence is a very, very powerful one. I think the goal, of course, of precision medicine is to develop a individualized paradigm of human health, meaning that each individual, we know that every single human being is unique. We also need to understand how the health trajectories of each individual is absolutely unique in biological terms, and I think we now have the capabilities to do that. And then we need to develop interventions to promote health and to solve disease using this highly individualized approach, right? So I think medicine is evolving rapidly, and one of the keys to that evolution or maybe revolution is AI, because it allows us to process huge amounts of data very, very fast, very effectively in ways that were just not imaginable even, just 5 or 10 years ago.
No, absolutely. And for the general audience that's listening, tell us a little bit more. Like, what exactly is precision medicine? Is medicine not precise to today or in the past? And if not, what does it mean to come closer to having precision medicine?
Yeah, so we'd like to. I think many people would like to think that the medicine or the healthcare that they're receiving is precise, but the truth is that in many cases, it's we base our knowledge and our practice of medicine not on what we are seeing in terms of individual characteristics of a patient, but more on inferences that we've made on the basis of analyzing groups and large populations, right? So what this means is, let's take a condition like that is very common, prevalent. Let's say hypertension, high blood pressure. It's estimated that about anywhere between 40 and 60% of adults in the United States will develop hypertension in their lifetime. So this is very, very common. And yet we are beginning to understand that the causes of hypertension are not single, they're not unique. There are many, many different potential changes or abnormalities that can occur that can lead to hypertension. And yet the way that we treat hypertension is what you would say like a sort of one size fits all. We commonly will prescribe the same medication to very, very heterogeneous groups of individuals who have hypertension. Not fully appreciating that some of those individuals may benefit from the treatment, others may not, some may actually be harmed, right? So when we talk about precision medicine, we're saying, why don't we leverage the more detailed biological knowledge that we can gain on individual patients to develop more personalized or more precise therapies? Why don't we why don't we leverage genomics, for example, to identify the specific abnormalities that are leading to hypertension, and then target those abnormalities in the treatments that we propose. This is what precision medicine is all about. It's essentially trying to tailor the therapies so that we, can deliver the right treatments to the right patient at the right time. And the reality is that the way that we practice medicine today is, it's a long way from that approach.
Got it. Now, one thing you mentioned that I thought is incredibly important is this advent of having all of this data, right? And I think the exciting thing in medicine in the last 20 years is, a lot of industries, including medicine, have started to go online, and better ways of capturing and providing data have been seen. But the other problem with that is that it's kind of like a couple hundred years ago when the microscope was used and we looked into a water droplet and discovered hundreds of thousands and millions of organisms. I feel like it's the same way now with medicine and data, where it's great that we have this data, but now we're getting an onslaught of all this information. And so doctors and nurses seem to be very overwhelmed with all the data and what to do with it. So do you feel that that's where, at least machine learning can help? And if so, where do we start in medicine? Where's the best applications?
Yeah, so I think you bring up several important points. So I think at the level of, where most doctors and nurses practice, I think many doctors and nurses feel overwhelmed because there's so much information that they have to process and document and read, to effectively deliver the care that they're supposed to, that is expected from them. But at another level, it is true that these very large data sets that are becoming available, so for example, genomics or different multi-omics, transcriptomics, metabolomics, knowledge of or information on the microbiome, and then also very detailed quantitative, imaging data and quantitative, physiologic data. These are things that are beyond the capacity of a single human brain to effectively process and analyze. So we do need, advanced statistical and machine learning methods to help us with that. But I would say also that, machine learning is useless in the absence of a strong biological sort of foundations and hypotheses. So I think the only way that this field can advance is the combination of three things. One is obviously the availability of high resolution, high quality data on human health. That's one thing. The second is, of course, the implementation of advanced statistical and machine learning modeling approaches. But I think the third piece of this that is really the key to success is, to have some strong biological hypotheses, that will drive the cycle of discovery. So you can't just expect, it's not as if you can magically put big data and machine learning together and then some solutions are going to emerge. You need to have the input of domain experts, people who have knowledge, deep and broad knowledge of human biology, of human medicine, to be able to really guide the process, move it forward. So it's really those three things that are essential in my view.
I absolutely agree, and that's the first time I've heard it articulated that effectively, because I think that one of the issues, in my opinion, that I see, and I'm here in I'm based out in Silicon Valley, is that the tech world looks at the medical world and says, oh, if you have all this data in the EMR, we can plug in and we can just consolidate all this data and then we're going to change medicine. But the problem with that is that you have to have some strong hypotheses. And I really love that you put it that way. Strong hypotheses rooted in foundational physiology, biology, that'll help say, okay, if we have the data on this and then we have some ML and AI capabilities, where's it going to be most effective and where's it going to make sense? Because if not, then you can start being led down a complete rabbit hole. And the one that I like to point out is Google. So my company, we're focused on fluid management and specifically on urine output for acute kidney injury. And Google, about a year ago, published a paper on predicting acute kidney injury within 48 hours. And so we were all very intrigued. We're like, oh, that's great to see this. Let's see what they have. And what they did was they took an algorithm and plugged into the EMR and based off of creatinine, which is unfortunately a lagging indicator. So you don't really predict AKI based on that, right? And so I think you're right in that the hypotheses have to be strong and rooted in physiology. Right now in medicine, what are some top areas that you think have strong hypotheses to use AI and data to change practice?
Yeah, so I think there are domain experts in many different fields of medicine, and certainly in oncology, for example. You can see how this field has been transformed, for just in the past 20, 30 years. The oncology was largely based on sort of clinical and, histological, gross pathological criteria 20, 30 years ago. And now it's largely driven by our understanding of the genetic changes that are either responsible for or result from the cancerous transformation of tissues. And these genetic changes are in many ways driving the kinds of therapies that we implement for cancer patients. So this is I think I would say that if you wanted to talk about success stories for personalized or precision medicine, oncology is one of them, and certainly a story that's still unfolding, but I think we can learn a lot from what's being done in the field of cancer. My field, which is intensive care medicine, I think is also on the cusp of, a major revolution. I think we have a lot of domain experts, people who are studying intensive care from different angles, who have very, valuable, deep insights into why people develop conditions like sepsis or ARDS. And we need those people to work closely with, the data scientists to effectively leverage, the power of big data sets in the intensive care unit. So, and here we're talking in the ICU of not just, physiology, the sort of physiological time series that is recorded on the monitors, but I think we need to go, many levels deeper. We need, I think the sort of revolution in intensive care is going to be a combination of, knowledge of physiology and also knowledge of biological changes that are the basis for the physiological changes. So I think so I think there's a lot that needs to be done, but I think that I can see this almost every day in my research group, because I'm very fortunate to have a group of people that are working with me. So this is a combination of clinicians as well as data scientists, engineers, computer scientists, and we meet very on a very regular basis, and it's a constant exchange, right? Because the data scientists are really looking towards me and my clinician colleagues for insights on human disease and human physiology, and we're obviously looking towards them for to develop the most effective ways for modeling and for classification.
Interesting. Yeah, and I want to take a quick sidestep. One thing I wanted to mention, and it was very nice that it happened this week since we're jumping on the phone with you. But I wanted to say to you and your team, congratulations. I understand that the NCCU team, or the neurocritical care unit, and the area of precision medicine was designated as a center of excellence at Johns Hopkins. Is that correct?
Yeah. So the Johns Hopkins, has developed a precision medicine, individualized medicine, has really understood that this is a strategic priority. And so the School of Medicine and the Dean Rothman, have decided that they would fund periodically centers dedicated to excellence in a specific domain. And so over the past few years, we've had precision medicine centers for example, for prostate cancer, I think pancreatic cancer, and it's a competitive process. So every year there's a solicitation and different teams can compete. So we were extremely fortunate to be selected this year, and we are in the early stage of putting together a center of excellence that is devoted specifically to optimizing the care and outcomes of patients admitted to the neurocritical care unit. We have several, short-term objectives, but the longer-term vision really is to do what I was talking about earlier, which is to, design the ICU or the neuro ICU of the future, where there will be this kind of seamless interaction between the sort of domain experts, the intensivists, the multiple data streams, and of course the different tools such as machine learning that will help us to really have a deeper understanding of why our patients are becoming so ill and how we can treat them.
Yeah, so the neuro ICU of the future, I think that's really interesting. And what I wanted to know is what does that look like to you?
One of the things that I think would be really important in the future is to be able to predict and prevent patients from experiencing critical illness or deterioration in their conditions. And so I think that we're close to being able to do that. I think what we need are highly precise and accurate models that can tell us if a patient is about to experience a deterioration like respiratory failure, sepsis, delirium, coma, stroke, heart attack, pulmonary embolism. These are all events that are potentially catastrophic, but that can be predicted if we have the available data and the appropriate models. So I think I'm hoping that the ICUs of the future will, first of all, I'm hoping that they're going to be a lot smaller, because we'll be so good at predicting and preventing patients from developing critical illness, so that we don't have to admit them to the ICU anyway. That's one thing. And then I think also we'll be very good, once the patients arrive in the ICU, we'll be extremely good at turning them around and effectively treating them, much more effectively than we do so now, because we'll have a much sounder understanding of their biological derangements. So I'm thinking of an ICU of the future that'll be, the real ICU, like the ones that we talk about or that we see today, will be much smaller. And the patients will stay with us for lesser durations of time. So that's one thing. The other way of conceiving it, though, is to think of it sort of paradoxically as much larger. And I'll explain what I mean. What I mean is that we absolutely need to develop methods to implement the kind of monitoring that we have in the ICU, to expand that to include the whole hospital. Why do I say that? I say that because we know, that if you take any sort of given hospital or health system, the vast majority of people, usually 80, 90% of them, are not in an intensive care unit. They're not in a monitored setting. And these are patients who usually are quite sick. That's why they're in the hospital. And they're at risk for deterioration. And so what we need, and this is where the input from my engineering colleagues and also people who are not my colleagues who are engineers is really valuable. We need to develop sensing and monitoring technologies and predictive algorithms that can help us detect when a patient in the hospital but not in the ICU is likely to deteriorate in the next few hours or the next few days. And so what I'm saying is it sounds maybe contradictory, but it's not. What I'm saying is that I think the future will look like this. We'll have the entire hospital will be kind of like an ICU because everybody will have wearable sensors on them that'll tell us, hopefully with high accuracy, if they're likely to deteriorate, and will give us a window of opportunity to treat them and prevent the deterioration from happening. So that's one thing. And then on the other hand, I think that the real ICU for the patients who've truly sort of fallen off the cliff, those will be probably smaller because we'll be so good at preventing those deteriorations. So I don't know if that makes sense, but that's kind of where I see things going.
No, it completely does, and it's interesting you put it that way. I totally agree. Again, I'm gonna I guess hedge against what I know really well, which is what we're doing here at Potrero, focusing as a precision fluid management company. And urine output and things like intra-abdominal pressure are important, but it's like a piece of the puzzle. But I know the nephrology intensivists who listen to our broadcast will appreciate this. But just a few months ago, they did a study in the UK where they compared creatinine to hourly urine output, and when they measured hourly urine output very intensively and compared it to the staging of acute kidney injury, they found that the staging was worse, and the incidence of acute kidney injury went up by like 30 or 40%. And the conclusion was that there needs to be better ways to measure fluids such as urine output. And I think it goes back to, on a very high level, what you just pointed out, which is that the whole hospital is going to be kind of like an intensive care unit in the sense that you'll have wearables and hardware that'll help capture and track data continuously, accurately, and in a streaming fashion. And when you do that, that's going to illuminate completely new paradigms in medicine on how we should not only detect but also predict illnesses and diseases. And then, of course, that'll help with different and earlier interventions. So that completely makes sense.
Yeah, so I think that's the vision for the future, and I think we're sort of heading there. I can tell you that I have a separate group of engineers who are right now developing a multimodality sensor, like a little Band-Aid that you can put on the chest. And, it provides like 6 different physiological variables. So, and we're doing some testing right now on this. But we're not the only ones who are doing this kind of thing, but it's certainly, I think, a paradigm that we're going to see a whole lot of. And it's going to be really important. I think it's going to open up this window of what I would call the preventability of critical illness. I mean, in a perfect world, intensive care, units would not exist because we've become so adept at, early identification and prevention.
Well, and we're getting, we want to be mindful of your time, so we're getting close to the top of the hour. But a couple other questions I had. So I'm gonna ask, and if you can't say it, you can say no. But I know that our audience will be mad at me if I don't ask this. That sensor that you're currently working on, what are the six different modalities and biomarkers you're trying to pick up, if you can share?
Yeah, I think it might be a little bit early to talk about that, but certainly I'll be happy to provide an update once it's more developed.
All right, so you're on the hook for that. So hopefully in about 6 months or a year, when things develop, we're going to have you back on because we would love to hear more about that. One thing that I think is interesting in the world of precision medicine, especially as it comes to data, is using vital signs that normally we've kind of glanced over and not taken so seriously just because there hasn't been a better way to pick them up, but to use them in a new way, whether it's respiration, urine output, pulse. Would you agree? And if so, what are some vital signs you think will be really important in terms of using machine learning on?
Yeah, so there's all of those signals. I think it's important to differentiate between these sort of episodic measurements that people have relied on until now, basically, and continue to rely on, which is, the nurse will go out and get vital signs once every 4 hours, once every 6 hours, and then we'll sort of look at those trends. I think the paradigm shift that we're talking about is continuous time series, which obviously are available already now in the intensive care unit, but which we're hoping will be available more generally throughout the hospital through the use of wearable sensing and monitoring technologies. And the reason I think this is important, this evolution, is because we know, I can tell you that our modeling has shown very clearly that the time series really are signatures of the underlying physiology in a way that the episodic measurements are not. So when you're able to sample, for example, the respiratory rate or the heart rate variability or the changes in urine output on a sort of minute to minute or even hour to hour basis, it's a huge difference in terms of identifying physiological signatures that could be associated with imminent or impending deterioration. So I think the sort of temporal component, understanding how that evolves, is really crucial. Another set of parameters that we didn't talk about, but which I personally think are really important, are the sort of physiological, neurophysiological changes. So, for example, EEG. I can tell you that in my intensive care unit, we do a lot of continuous EEG monitoring. And that's just an incredibly rich signal, and the possibilities in terms of deriving meaningful quantitative features from the EEG, from the continuous EEG, are really huge. We're just only beginning to leverage that right now. And a third area, which I think, which we don't often think about either, especially for the intensive care unit, is imaging. And my group has been working, for example, on quantitative approaches to CT scan and MRI, and it's very clear that the way that we currently use routine tests like head CT or brain MRI is really just kind of scratching the surface. There's a huge amount of information in those types of studies that we're not at all exploiting, and that we can analyze using quantitative, sort of systematic quantitative approaches.
Interesting. Now, before we wrap up, and again, we appreciate you spending some time out of your day to chat with us. I do have some interesting, we call them rapid fire questions. We like to ask all our healthcare leaders these questions, and you can take as long or as short of a time as you'd like to answer them. So, of course, if you answer the question fast, then I'll move on to the next one. But otherwise, you can take your time on it. So the first question, and actually it's good because it's something that you and I were very much able to relate to. But both you and I were really into books. From my understanding, you get, like myself, you get in trouble with your spouse for ordering too many books on Amazon. So I'm glad that there's someone else out there like me. But for all the people who are listening, especially the young leaders in medicine and healthcare, what's a book that you most often recommend, or perhaps a book that you read recently that really influenced the way you think today?
That's a hard one because I do read a lot. I'm very partial to fiction and also philosophy, but in terms of more sort of practical business-oriented books, I like the work of Nassim Taleb, who he wrote The Black Swan or Fooled by Randomness. I think those are really, really very thought-provoking books.
Yeah, that's a good one. I think he did also Skin in the Game too.
Yeah, I have not read that most recent one, but I think he's very smart, very thought-provoking. I also I'm very interested in the work of like Daniel Goleman, like on emotional intelligence. I like the Daniel Kahneman, work Thinking Fast and Slow. I think those are really interesting books that I've really enjoyed quite a bit.
Oh, those are fantastic recommendations. Yeah, so I completely agree, and I'll leave links in the show notes for our audience. Next question I have is that let's imagine or pretend, and we can wrap up on this last question. So I want you to imagine that everywhere in the United States, you're going to have a billboard that's going to stay up for 1 year, and every medical peer of yours is going to see this billboard as they go into work. What message would you put on that billboard?
Probably pay attention. I say pay attention because I think, the reason it may sound very simplistic, but I think a lot of the, we can gain so much by just paying very close attention to our patients, to our behavior, to their behavior, to our interactions, to gaining insights on health and on disease. So I think I would just say pay attention.
Yeah, I really like that answer, and I completely agree. I think, whether you're a physician or someone who works in the world of tech, I think the benefit of all this technology is that, yes, it does make things a little bit easier. It makes us more efficient. But more importantly, the hope is that when technology lifts the burden of some of these manual tasks and things that we don't like to do, we have to go back to strengthening our own minds and being able to pay close attention to things. And I think that's a big part of the human spirit.
Yeah, I couldn't agree more. I mean, I think, so some philosophers have opined on this subject, but you can make the case that if we were really good at paying attention, we could probably solve many of the problems that we see around us. So I think that's we're usually in so much of a rush. We're inundated by so much information that we fail to appropriately pay attention. When I say pay attention, it's not just I don't mean moving away from the technical world. I mean actually just being more insightful in the way that we appreciate what's going on around us and trying to interpret it in ways that we hadn't been able to do in the past.
No, completely. I completely agree. Well, Dr. Stevens, we really appreciate you spending some time and coming on. Again, you're on the hook with us, so hopefully in about 6 to 9 months or a year, we'll have you back on. We'd love to hear updates from your research group and how things are going. But again, thank you for spending the time with us today.
Yeah, my pleasure.
Perfect. Well, have a great day, and for everyone out there, we'll see you next time. Hi, everyone. Thanks for tuning into this episode of Hills and Valleys. If you haven't already, go ahead and hit that subscribe button on our podcast. That way you're notified of new episodes as they're released. And if you're not already, please go ahead and follow Potrero Medical on all our social platforms, Instagram, Twitter, Facebook, LinkedIn, and YouTube. And we'll see you next time.